You're live on YouTube. Anybody can join on YouTube and watch it as well. Hi, Glory. Hi, Edwin.
Hello.
How are you? Welcome.
Thank you.
Nilani? Welcome, Nilani.
Hello. Hello, Maru. Hi.
Hi.
Hello, Glory.
Hi, Nilani. Nice to see you.
Oh, at last I've got it.
You're on two things. That's why you have to close one of them. Your phone.
Right. I'll close the...
It's 39.
Close the phone and you can talk on the. That's it. Close it completely. You're still there. So you will echo.
Cancel power off.
No, wait. You move your hand on the. I think your computer is also working.
Yeah. I'm going to knock off the phone is on.
So phone you'll have to then disconnect.
Yeah. In case one fail, for the first time I'm seeing on the laptop.
Turn towards the window. It's better.
Sorry?
Your face is not seen well.
What should I do?
Can you come to the window? Or have a light in front of you or table light or something on your computer? Stanley's son is here already from 12:45.
Good morning.
Yeah, Sheikh,
Yeah.
Everybody.
Is that better? Maru?
Wow.
So Nilani.
Working?
Yes.
Prima. Yeah, obviously it's
Hello,
working.
Prima. After a long time.
Yeah.
Long time, yeah.
It's on Zoom then, on phone. Yeah. Okay. Karunian has an internet problem.
Maru, is this better? I have put a light.
This is better, definitely.
I think there's still a dark.
Dark because your window behind is shining. So that's taking the light off. If you close the window behind, which is where there is light coming through, your face will be better. Hi, Mohan.
Hello, Al-Hajj, Mohideen, how are you?
Better.
Hi, Mohan.
Hello.
Window එක වහන්න බැරිද? Curtain. නෑ තව light තියෙනවා වැඩි. ඒ window එක වහන්න බැරිද? curtain එකක් නැද්ද? Ah, there you are. Thanks, Karunya. Then
Hello. Hey, Maruf.
Yeah.
I managed to get in. I don't know what the hell happened to my Wi-Fi. But anyway. Yeah. Okay. I'm can you see me?
Yes, we can see you.
We can see you.
Okay, good. Great. Okay, I have to go out and get the phone. This is the modern day world, some guy must have sabotaged the internet. Yeah. Hey, Narada, how are you?
Hi.
How are you? Yeah. A little bit of a struggle to get in.
Nilani, you like to place your phone.
Yeah.
I have knocked off.
Hi,
Yeah.
Lani, after a long time.
Glory is not there.
Hi, Glory.
Father,
Hi, hello, hi.
Yeah, Nilani, you look very scared. What are you scared about?
about technology. I am at the lower rung of the ladder. We just managed to get in. Hello, Saro.
Hi, Nilani. So good to
Hi,
see you here.
Hi,
Hi,
Saru.
Saro.
Hi.
Hi. Hi, guys.
Hi.
Dharminder is,
Yeah, I think hold on for 1 minute. Maru, give me 2 minutes. I think I can get into my internet through my
no problem.
computer.
Keep
Give
on
me
and
1 minute.
shut the phone.
Okay.
Leave the
Hold
phone
on.
connect up. Yeah.
Hello.
Hello.
Everybody will see Sharvinder there.
Hello.
Can you all see?
No, I can't see Shavinder.
Sharvinder
No, we can see, but he's muted.
is muted. Yeah.
Good morning.
Morning.
Guys, give me 2 minutes to
No problem. No
get into
problem.
this.
Yeah.
Oh, I got it. Okay.
Alhamdulillah.
Great. I am now in. Don't worry.
Praise be to God. It's not the internet.
Maruf, I cannot get the brightness of the room any better. I don't know what to do.
Right, that's enough. Everybody can recognize Nilani?
Yes.
Okay, that's good. Hi, Milroy.
Hi, morning, Maruf, and the rest.
Hi,
Hi,
Pierre.
Milroy.
Hi.
Hello.
Hello.
Malal.
Hi.
Yes, hello.
Hello.
Nan.
Hi.
You look professional. Narada, you look professional.
Yeah. Huh?
You can see
Hello.
because
Hey,
you are
guys.
at the back. Oh, Karni, welcome.
Yeah.
My goodness.
Sorry, guys.
Now we can see the speaker as well.
Yes, he is there, bright and shining.
That's more important.
You recognize him from the picture. He's somewhat like Stanley, of course.
Hello.
Whole block.
Man, 5 o'clock is very early.
5 o'clock for Karni and poor Karni.
Karun, and is he there?
And he has gone to his son's place and they didn't switch on the internet until 5:15.
He's muted.
Karunian is muted.
Yes. Karunya on your mute.
Okay, all right. Can you hear me now?
Yeah.
Yeah.
I can hear you, yes.
Great. We are waiting. How many more people are we waiting for?
We are not waiting for anybody.
See them, but they can't see me.
Okay. Vijay is not here? Stanley?
Stanley
He's
will
sleeping. He doesn't want to listen to his son anymore. Huh?
He must have heard it before.
He just waiting for me.
Yeah.
Yes, that's enough from him.
Shall we wait for 2 more minutes or 5 more minutes?
Who is NG? Is that Nihal Gunratna?
NG.
Nilani
Nihal
Gajavira.
Guru Singer? No.
Ah,
Nilani Gajavira, please, NG. can you please switch off your phone?
I have.
Anyway, Nilani Gaji, then it's somebody else. Nihal. There you are. He's appearing.
Ah, that is right. My guess was right.
Yeah, Nihal is right.
Now, it's
Hi,
a
Nihal,
proper
how are
pair
you?
there. Can you see Nihal next to Saro, as it should be?
You managed.
Mohan, long time married Mohan.
That shouldn't make an exception. That is to be continued.
Shanti is just joining.
So, yeah, shall we give 3 more minutes or 4 more minutes? Let me introduce Shavinda. You are muted, Shavinda. Can you hear me?
Yes, I can hear everybody.
Yeah, we can hear you.
Good.
I'm just
So,
enjoying
Shavinda,
the
just as
banter back and
background,
forth.
you know, your father has decided not to come in yet. I thought he will join.
I'm sure he's right now having an internet crisis at his desk.
Yeah, that's what I had. I had an internet crisis and I was delayed a little bit coming in. Yeah, but it's early morning for us. It's 5 o'clock in the morning. So there is Stanley. Yeah.
Hello.
Yeah.
Waiting for you. We didn't want to start without you.
Hello, Stanley.
Hi.
So,
Good morning.
Shavinda, just to introduce us to you, you know, we are all people of the class of 1966. Okay. So we graduated how many? 55 years ago, I think.
Yeah.
That's amazing. Yeah, we are all young at heart, and we are from the whole world really. Now we got a friend of ours who regularly comes from New Zealand. He hasn't come in yet. Where's Banda? Banda is sleeping.
I'll call him.
And then we have a bunch of people from Australia who also haven't come in today, right? Where's Benita and Vicky?
No, Benita probably should come because she had sent the email. Hi.
But we have Kodda from New Zealand.
I'm in Glasgow now.
Okay.
So we are all. So we get together and learn a little medicine and chat a little and have some fellowship.
12 midnight.
But your topic today is a topic I think that affects all of us in one form or another at some point in our life. So it's going to be very important that you tell us how to take care of our backs. And I'm sure all of us at some point or other would have had some back pain. Hi, Vicky. Yeah.
Hi.
Yeah, so we got Vikramacharan from Australia.
Hi, Vicky.
So I think, Madhav, do you think we can start or are we waiting for anyone else?
Hi, okay, I saw you. We were wondering
Just a small personal note on Shavinda. You know, Shavinda is a very distinguished orthopedic surgeon in New Haven, Connecticut. He specializes in back, but when he was a year old, he got pretty sick and I took care of him. He doesn't know that. You know, Vijay knows it. He got a bad diarrhea and I had to put him in the hospital and give him some IVs and never thought that he would be this handsome young distinguished orthopedic surgeon who teaches at Yale at that stage. So some of his credit, a little bit of it comes to me now. But I think Vijay and Kumu, his lovely wife, have done a wonderful job. And Shavinda is just a very, very nice guy. He's one of the few young people who regularly sends me Christmas cards with his 4 lovely children and his wife. So he's just a delightful young man. And Shavinda, truly a pleasure, and it's lovely to have you talk to us. And do you want to say anything? Anyone else wants to say anything else about? We won't say all the bad things about your dad. We know a lot of stuff, but we'll keep it for another day. Today we'll say good things about him. But I'm sure he's very proud of you, as we all are. And I'm personally very proud of you and very, very pleased.
Just one question. Is Shavinda the only child of Vijay Sekar?
No. Vijay Sekar. Yeah, go ahead, Vijay. Sorry. Vijay, go ahead.
My eldest.
Eldest. Okay. Yeah. And how many others?
I have 3 others.
Good.
But nobody did medicine.
Right.
One did best. Next thing best, he got married to a radiologist. That's my youngest daughter.
Right. Okay. Thanks.
Yeah. I'm so proud of him. And, being a father, of course, everybody will be proud of a child. But this guy did everything better than me. He got married before my age. I got married. He went to med school before I got married. He finished his training before my age of training. And everything he had done better than me. So I'm so proud of him too.
Yeah.
What sports did he play? What sports?
Can we share the pride? I think we are proud too.
Okay, thanks.
Yeah, he also was really a nice guy.
What is the sports you played?
Yeah, known him
Well,
from,
I encourage him.
Hold it. One person, Milroy is talking. Milroy also had known him from his childhood.
yeah, from his childhood. He was a very nice guy, very humble guy, and he's still so humble and talked to us, sends us cards, and I have talked to him a few times. I'm so happy that he has distinguished himself as a leading spine surgeon in Connecticut. Everyone knows him there. And so keep it up, Shirley, and we are very proud of you.
Thank you.
Yeah, no, actually, one anecdotal thing, Shavinda was consulting in a hospital where Nalin was working, Nalin Pereira. Nalin is not here today. I don't know where he is. Shavinda, he's also in our batch. You know Nalin.
Yes.
Yeah.
They're going to his
And
house.
so Nalin called him for a consult, and he came to the hospital and started calling him uncle. So all the nurses, they were mystified as to how this big time orthopedic surgeon coming and calling Nalin uncle, and so it was a nice thing. Nalin always remembers that, and he mentions that. Yeah, but truly, Shavin is a very, very well-known orthopedic surgeon, but he's also a very humble guy and and one of the few people who sends me Christmas cards. Though he hasn't sent me Christmas cards the last few Christmases, Shavin. I think you must have.
Back on it.
Okay.
All right. Do you want to start now, or anyone else with any questions or comments?
I have a question for Stanley. Where's Kumi?
She's here.
Okay.
But
Hi.
Hi, Kumi.
Hi. Where's Kumi?
Yeah.
Hi, Kumi.
Hi.
Glad to see you here.
Yeah.
Forgetting an important part of Shavinder's upbringing, Kumi.
of course, she deserves more than 50%.
Exactly. Need to recognize her.
Stanley.
Yeah.
What's your son's extracurricular activity?
You better ask him.
These days, it is really, I have 4 children. That is probably the extracurricular activity.
That is the only place where he could exceed me. He had decided not to exceed me on that. We are equal on that.
Yeah, equal on that, yeah.
I joke and tell people that my real job is I'm really the Uber driver for these 4 kids.
I asked that question because you must be very physically fit to do orthopedics.
Yeah, you are muted. You can.
Am I muted?
Yeah.
You can hear you, yeah.
No, I can't hear you.
Can't hear.
Okay, so shall we start the
start? Yes.
Okay.
Yeah. Okay. So with that introduction, Shavinda, you are on.
Okay, great.
Share the screen, Shavin.
Sure, I'll share my screen. So good morning, everybody. Thank you for having me. I really appreciate that everybody is joining from all over the world here. Let's see here.
Los Angeles, New Zealand.
Oh, that's right. All right, so there's my screen. Can you guys see it?
Yeah. Yes.
All right, let's see if my technology will behave. There we go. Okay. So, thank you for inviting me. I was a little surprised when I heard that I was going to give the talk, but I'm happy to do it. It's no problem. And I put together a few different things from a couple of different talks I have, and really will confine it to the lumbar spine today. So, how do we think about the lumbar spine? It's really an evolution, over the course of all of our lives. You start out great, you can do anything. And then there's a little bit of reality that kicks in, and the road of your lumbar spine throughout your life's a bit bumpy. But with a bit of maintenance, it can really keep us going throughout the entirety of our life. And I think Dr. Seuss has a good quote that is quite helpful for this. If you have brains in your head, you have feet in your shoes, you can steer yourself in any direction you choose. So with a little bit of knowledge, you can continue to direct how your body is going to behave and keep yourself going so that you can do the things you like to. To this group, it is an amazing thing. I was talking to my kids and my wife about this, how you as a group are such role models. Here you are, you're all really literally all over the globe, from continents, North America, Asia, Europe, Africa, Australia. The only thing missing is South America. There are probably some folks that are there. And Antarctica, I hope really no one is there, though my father thinks I live there sometimes when he comes to visit here. Countries far and wide, really. Sri Lanka, US, Canada, New Zealand, Australia, Malaysia, Saudi, UK. I mean, these are just what I got from you guys. So I'm sure that there are more spots around the globe. And this is only the class of 1966. And your group is so good about staying in contact with the classes above and below. I am very impressed, and really you should be proud of yourselves. And here you are, graduated 1966, but on Zoom and YouTube and doing this in the middle of a pandemic. So congratulations to all of you. Sri Lankan physicians, who are we? They're a clearly innovative group. Here's the world on the left before, and here's the world today. But despite the world looking like coronavirus, everybody is on this meeting. But how did I get here? I have some amazing role models that got me here. Here are my parents. They are so much better than me. I don't know. I mean, they are adventurous. They are brave. They are visionary. They, like you all, are able to do so many things that I don't know that I could pull off. They, left Sri Lanka when they were young, no family, maybe a handful of you to support them, but that is a pretty serious leap. I doubt that I would be able to do it, and I doubt that I would let my kids leave myself to go on such an adventure. But thank goodness they were brave enough, and thank goodness they had the vision to stay. Otherwise, who knows where I would get to. My father has said to me, he's said, no one can take your knowledge. Be smart, work hard, do better than me. He said it even this morning. So here I am trying to keep up to that, but I don't know that I can, because here he is. He's out on the Long Island Sound with me kayaking, no problem. He travels to Hawaii, to Sri Lanka. He is way more adventurous and more capable than I am. It's really funny. And I'm trying to do better, but I'm still working on it. Here they are with all of the grandkids. This is a pretty, just this picture to me sums up success, and that something really went right. And, we all should strive for something like this. And I take this as an example. Knowledge, it just doesn't end. Here you are, today on a Saturday morning, waking up at all kinds of hours for all of you, and you're still trying to keep your knowledge going. Working hard, we're all trying to evolve and keep going and trying to do better. So I'll tell you a little bit about myself. I went to school at Boston University for my undergraduate studies, and then stayed there for the Boston University School of Medicine as part of a 7-year program, which was really such a blessing in my life. And then after I graduated, I went back home to USC, and I finished my orthopedic internship and residency there. And then really was drawn to spine surgery, and was, it's interesting, like when I was applying to fellowship, 9/11 happened. And so the realities of travel, we didn't have, the Zoom wasn't there. So your ability to travel around around to go to interviews was really restricted. So I ended up really fortuitously landing at UC Davis with the next president of the Scoliosis Research Society, my mentor there. And that was a fantastic experience and really set me on my career to be a spine surgeon. Afterwards, these are my 4 kids, and my wife is from the East Coast. So the realities of trying to stay in California just did not happen. So my mentor said, well, where's your wife from? I said, well, she's from the East Coast. Well, that's where you're going. So here I am. I'm in a private practice in Connecticut, and I've been on the Yale faculty since the beginning of my career in 2004. And then the reality of time passing and realizing you're not the new guy anymore. Now I'm the old man around, and so now I'm the chief of orthopedics here at Yale. And I try to, in this idea of trying to do better, I'm trying to be a global citizen, and that really takes me to my professional love is to try and do a little bit of worldly work to try and do better in this for patients around the world. So World Spine Outreach is a nonprofit that I am the medical director of, and we have been delivering scoliosis care around the world for about 15 years. We've gone to places as far as Dominican Republic, which is our main base where we have gone for 15 years solid, but all the way to Vietnam, even done some surgeries in Europe. And it is a busy time when we go for that week in 5 days. We're typically doing between 20 and 40 surgeries. And it has really been such a rewarding part of practice, partnering with local teams, and we've developed and grown together and learned together. They learn from us, we learn from them, and the partnership model is really quite good. We participate with their residents, our residents go to them, and it really creates more of a global kind of a scenario. So World Spine Outreach, we're a huge group, as you can see from this picture. We're surgeons, we're anesthesiologists, we're nurses, neuromonitoring folks, implant reps, even cell saver perfusionists. We take our first world techniques, we take our standards, we take our staff, and it really brings up their program, brings up our program, and it really is an international diverse group. We have some surgeons that even come and join our team. They come from Korea. They come all the way from Korea to Dominican Republic. I suspect some of it has to do with nice weather in the middle of the winter, but that helps as well. Here we are treating kids in these places, and it's primarily children. There are some adults, but we really try to concentrate our efforts on the children, because for a lot of these places, if these kids are deformed, and they tend to be mainly females, if they don't end up getting married, their future is really curtailed. So if they are badly deformed, then it really has a long-standing impact upon them, their families, and society all around, because the reality of public health and things is that the world is really run by women who really keep things going. So we train the local teams, we develop the partnerships, and it has really been an amazing part. And what is it to be an international spine surgeon? It's really, you have to bring your A game, really. It's bring your A game, bring your A team, and bring your A attitude. If you come in with a bad attitude or you're not flexible, it really will impact it, because it is very challenging pathology. It is a generally challenging patient pathology. They tend to be malnourished, and it is a more challenging work environment. We do not have all of the logistical things that we would have available to us ordinarily, maybe not even air conditioning, So you just have to work with what you have. But with that kind of a thing, you're able to take, tremendously deformed kids and really straighten them out in the few hours and really put their life on a completely different path. So I'll make a shameless plea here. I get asked all the time, why don't we go to Sri Lanka? So I would love to do this. I'm sure that we can learn a lot from the surgeons that are there. We can teach and they can teach us, and it would be such a great experience. So that would be something that I would love to set up. I'm not sure how we go around doing it, but someday. So let's go on to, to the lumbar spine today. I'll go over a few kind of generalities, anatomy. We'll look at how does the pathology develop. And there are really four tenets or four issues that we ought to look at with regards to the lumbar spine specifically: spondylosis, disc herniations, spondylolisthesis, scoliosis, and then maybe we'll touch a little bit on the future aspects of it. So from an anatomy standpoint, you know, most of us have 5 lumbar vertebrae. Some of us will have 4, some will have 6, but 5 is the generality. And we typically have a little bit of sway back in our lumbar spine. We call it lordosis. And here's a pretty normal looking picture. You know, the vertebral bodies are nice and square. The discs have a nice tall space here. And the alignment of it is that all the vertebrae are nicely stacked one upon another. So this is a nice, normal, healthy looking lumbar spine. And as we kind of drill down on each level, each segment of the lumbar spine, think of it as like a tripod. It is a 3-joint complex, the disc being up in the front here, and then 2 left and right facet joints in the back. Within that tripod, within that triangle is the spinal canal. And here is where the nerves resides. And they travel off through the holes here, off to the side called the foramen, and go down each leg left and right. The disc is in the front and the muscles surround the structure and provide mechanical dynamic support to it. So if we look at the skin from the outside, the top of our iliac crest is usually around the L4-5 level. The dimples on our lower back are the posterior superior iliac spine. And when your lower back aches, you kind of tend to rub the area. And it's pretty common to feel a little bit of a roly-poly lipoma in that area. As a generality, some patients will ask me, oh my goodness, I have this terrible back pain, and they feel this lipoma thinking that they have a tumor. But that is really a pretty common finding for almost all of us. In the middle, there's a nice sulcus where the paraspinal is attached to the spinous process in the center here. And if we look at the muscles, we go below the skin to the next layer here. We see these paraspinals, okay, and there are 3 typical bundles of them: the multifidus, the longissimus, and the iliocostalis. All of them grouped together and attached around that posterior superior iliac spine. And then up in the front is the psoas, which covers the front aspect of the vertebral body. And they all have a part in our overall function and care. So as we go down and go deeper, we get into the bony structures, okay? And the main critical portions of this are going to be the vertebral body up here in the front, the pedicle, which is critical for me when I'm trying to treat these things. It connects the vertebral body to the posterior complex here in the back. So that's this pipe of bone that runs front to back. And then the other 2 legs beyond the disc here are the facet joints, left and right. And then the superior and inferior articulating process, the facet joints are connected with this structure of bone called the pars. And it's a thin structure and is at some risk and maybe a function of human evolution. As we stand up, it sees some undue biomechanical forces that, you know, quadruped animals don't necessarily see. And then typically, you know, when you're touching your lower back and you have back pain, you really, the bony prominence in the back is just this flange here. This is the spinous process. And then we get into what's between the bones. The between the bones is the disc. It is a really remarkable structure. It probably could be engineered better, but this is what we have. Think of it, I describe it to patients as having a jelly donut appearance to it. The outside of it is called the annulus fibrosus, and it has this, and you can appreciate it in the picture there, some circumferentially oriented fibers, but it's a remarkable design in that it has this cross-hatching to it, which kind of adds some strength to it and increases the overall strength. And interestingly, the disc, though it is the source of so much pathology, only the outer third of it at best, the outer third of this annulus has any real innervation to it. It's largely, insensate and avascular. So this central gelatinous, more normal appearing material here is the nucleus pulposus. It's avascular. It has a very high water content, and that's what really gives it its viscoelastic properties. If we look beyond that to the critical structures of the nerves, and this often dictates the nature of the pathology. The spinal cord ends at around the thoracolumbar junction, so we would say L1, T12, depending on where we are. That's where the spinal cord ends. But when we talk about the lumbar spine, it's really primarily cauda equina, so the spinal cord is ended, and these little collection of nerve rootlets reside within the CSF. They clump together and form the larger structure, which is the lumbar nerve root here. And depending on how the nerve root, which one we're talking about, will give us a different dermatomal distribution. Now, it's really a terrible part of medical history to know that most of these dermatomal maps came from prisoner data, where they severed a nerve and then asked them where they were numb. So this is a generality. So most of us, L4 will be around the medial aspect of our ankles, and it will govern the motor strength to the tibialis anterior, which can be important for something called a foot drop, where the muscles that control the foot are not pulling the foot up, and essentially it drops and can make it difficult to walk. It has a reflex that we can test on physical exam, which is the patellar reflex. We typically think of that as L4. L5, maybe the most common root that's affected. It's also the one at some more risk. It has relatively poor blood supply. It has a relatively tethered course as it travels from the lumbar spine over the sacral ala down the front. So it is at some risk, and maybe just why it tends to be most of our pathology. And that dermatomal distribution is on the dorsum of the foot. And then S1 will be that lateral aspect of the ankle, moving on to the plantar part of the foot. So why does our lower back hurt? Sometimes you have some dramatic findings. You could try to pick a fight with Conor McGregor and get into it, or you could find somehow in New Haven a way to get stabbed with a ice axe here. And sometimes these are some obvious causes. Hopefully none of us have these, but back pain is ubiquitous. It affects all of us. And so it can be simply an ache. It can be really severe, disabling pain that arises for no good reason. It can be a burning pain. It can be leg pain. It can be back pain. It might just be numbness. It could give you a sense of weakness or actual genuine weakness. So it has a tremendous variable presentation. Having said that, it's ubiquitous. We can all expect to have at least some amount of back pain, and it's a little bit of reality that we will have to learn to manage and live with it, but it is in some ways to be expected and normal. And what drives this? This is really, Kirkcaldy-Willis, this paper is really the backbone behind understanding what is it that drives all of these things, whether it be lumbar spondylosis, whether it be a disc injury, whether it be spondylolisthesis, or even scoliosis. So it has three tenets that they were able to identify. This idea of an injury or dysfunction leading to instability, and then the instability, as the body tries to heal it, leads to stability. So it might be, say, something like, this is a busy slide here, but it might be that there's an injury to the facet joints and there's a bit of an effusion in the joint, and it leads to some injury to the cartilage, which leads to some alteration in the mechanics. If you think of it like a door hinge, if that hinge doesn't spin really nicely and smoothly, then the door will be creaky, or it will not slide and open nice and smoothly. The disc, on the other hand, you can have a tear in the disc. It can progress all the way to a disc herniation with some impingement upon a nerve root, leading to sciatica. If those things don't happen, then the body tends to develop osteophytes, which are the Mother Nature's way of treating osteoarthritis, and the concept being that it hurts when it moves. So if there's less motion, it'll hurt less. That works well. It leads to some stiffness, but sometimes if it goes awry, it can lead to something called spinal stenosis. Or if the stability doesn't develop in an effective way, you can lead to instability and go on to develop scoliosis or spondylolisthesis. As part of these injuries, it is really remarkable to say that how important the muscles are. So while the joints and the disc will always degenerate, if we can maintain some strength and functionality to our muscles, then we can really overcome this and really avoid suffering from the realities of having osteoarthritis. So on the left here, this is a pretty normal looking paraspinal group of muscles that has healthy color through it. And on the right, you can see this white infiltration into it is really fatty infiltration. The muscle fibers have atrophied. They've developed fatty infiltration. So they're just less effective at controlling and maybe working to overcome and fight some of this arthritic changes. And if we drill down, and this is not entirely my world, but drill down on the cellular level, why does this happen? And maybe this is the future leverage point, is that at the cellular level, there are so many changes that occur, and it might be the disc being avascular, that there's a change in the extracellular matrix resulting in changes in the level of proteoglycans and water content. And the altered cell signaling leads to inflammation, whether it be hypervascular or an influx of nerve fibers leading to erroneous signaling that tells you, your lower back hurts much more than maybe you would like it to tell you. So the disc here, again, being avascular, really gets most of its nutrition from osmosis. So when the cell signaling becomes disrupted, the extracellular matrix changes, and the ability of the disc itself to heal itself is really quite compromised. And maybe this is the crux behind why we all get lower back pain. The disc just cannot repair itself entirely. Along with that, the increase or the up-ramping from the neurotrophins into the area increases the sensory fibers that go to the paraspinals, go to the disc, and maybe create this perception of increased pain. So let's go at this from symptoms, right? Sciatica. Sciatica is this experience that you can have pain that travels, classically described as an electrical shock, traveling into the buttocks, down into the legs, maybe into the toe, but it has such a variable presentation. Some patients will have only butt pain. Some people will have only toe pain. And some people will have that more classic linear electrical stripe to it. Depending on where the symptoms are, it might kind of lead you to understand, is it my toe? Is it is that the L5 root? Is it my ankle? Is it the L4 root? Is it something more proximal, where it's just in the thigh or in the anterior aspect of the thigh, maybe being an upper lumbar root? But as sciatica develops, the earliest pathology, which is pretty common, is a disc herniation. So on the left here, we see a pretty normal looking spinal canal. That white, blue outlined structure here is the normal spinal fluid with the dura, and then the little dark dots inside are the nerve rootlets. Now this looks pretty normal here. The picture in the middle kind of has this round, circular, kind of grayish material here. But if we look at it a little bit more carefully, what you can see outlined in yellow here is that is the disc, and all of the nerve rootlets have been shoved entirely off to the left side. So it's a pretty large injury here that is impinging upon the nerve root and might give somebody the symptom of sciatica. Sometimes that arises from no particular injury. So the anatomy will really help to understand why and where we have it. So the anatomy tends to dictate the symptoms. It's a common injury. If we look at the data on this, the incidence at any given time is somewhere between 4 and 11% incidence of having a disc herniation. So all of us can expect to have a little bit of this. You might have some sciatica. Some patients will experience mainly back pain. The posterolateral aspect of the disc is where it tends to be. If it arises, say, straight anteriorly, which is very much less common, there's largely no consequence. Maybe you would have no symptoms at all. But this posterolateral aspect is the very largest group bucket of patients who have this, and it tends to get really the traversing route. So the L4-5 disc will injure the L5 nerve root as it passes it. On the other hand, if that same disc has a more lateral position, in what we call the far lateral position, it might really get the L4 nerve root. So this might present entirely differently, where someone might have an ankle pain, they may have weakness. This L4, this traversing paracentral kind of location really will get the more classical L5 nerve root distribution. So what drives something like this? Typically it's a rupture of the annulus. And as that disc ruptures, the annulus tears. It could be not even a full tear. It might just be a fissuring, like a paper cut. Might be a small injury, but have really dramatic impact. And what the reason being is that disc, again, being avascular, is entirely immune privileged. So the material that's within the nucleus is never really exposed to the body. And so when it does become exposed, it creates a tremendous inflammatory response. And inflammation is the hallmark behind which all of this pathology gets driven. There's some component to it being mechanical. In this bottom picture, you can see a fragment of it can actually physically squeeze the nerve. But in most people, the most dramatic aspect has to do with inflammation, and which helps us to come to how do we go on to treat it. The natural history of having a disc herniation is really pretty favorable. Almost all of us will have an injury, something like this, but about 80% of us will resolve with conservative measures. That tends to be most patients. It tends to be anti-inflammatories like an ibuprofen or their prescription cousins, physical therapy, and really time is the thing that really makes a lot of these better. It can take as long as 6 months. It doesn't go from 0 to 100% better, but it takes some time. There is a smaller group that do ultimately need surgery, maybe 10 to 20%. They are kind of 3 larger buckets: people who have a neurologic deficit that is problematic. They are in such severe pain that they cannot wait for it to improve, or after going through some conservative treatment, the symptoms don't resolve. Patients, as a generality, nobody wants what I'm selling. Nobody wants lower back surgery at all. Having said that, the data on it is really quite reliable, that those patients who fail conservative treatment, okay, if we're looking at that 10 to 20% group, as a generality, those people tend to do much better over the course of time, while if they don't have surgery, they're not going to end up paralyzed or something like that, but what it tends to continue to nibble at them and impact their activities of daily living. So in those patients with a persistently symptomatic disc herniation, they definitely do better with surgery, and there's good data to back this up. So here is a little bit of my world when I'm treating these things. This is an intraoperative view under my microscope. So the structure here, this white, is the disc injury that I tend to see when I'm looking at this. This is the dura here, this number 3 running north to south. So this is on the patient's right-hand side, and this is the lumbar nerve root, which is kind of displaced. And then as I start to mobilize and have a look at it, I can see this kind of large material, and I keep retracting the dura off towards the midline because, again, it is paracentral and it tends to be underneath that dura. Now I can see this kind of lobular kind of white material. This is the nucleus that has been extruded, and this redness to this root, okay, normally this should be really a pearly white color. This redness is typical for what we see when we're looking at it. It tends to be inflamed and angry. And then here in the final picture, we've removed it, and the nerve root itself has a much more normal trajectory across the surgical field. And this something like this, you can almost imagine that the patient is just saying, ah, as I grab this, and just feels so much better. So leaving sciatica and the more ubiquitous aspects of back pain, you know, it can be like a Sri Lankan beauty contest. So it can be unpredictable. It can hurt. It can be incapacitating. The back pain can feel scandalous and dramatic, and you never know when it's going to happen. So we go on and we look at, like, why do I have this back pain? What happened? It tends to be, it progresses again through that Kirkcaldy-Willis cycle of starting with some disc degeneration. So this picture on the right shows, you know, maybe the white structure, and the one that is isolated there in green, that has a little bit of a darker color. It has a different surgical picture, or excuse me, a different radiographic picture to it. The one on the left is a pretty typical lumbar spine, some osteoarthritis, some back pain, but overall the structure is really quite good. So this is somebody who's been having back pain. They said, well, why does it hurt? What can you do? You look at this and you say, really, we shouldn't do much to this. We should really manage this with conservative management, because it tends to follow this Kirkcaldy-Willis cycle and get better, and they leads to stability. So what are the methods by which we would treat, just say, the typical lower back pain? This lower back pain that is lumbar spondylosis, whether you are in your 30s or whether you're in your 80s, you know, tends to be treated conservatively. Optimize your weight, easier said than done. Stretch your hamstrings, core strength, and the last tenet would be some kind of cardio. And it's hard to achieve kind of the tenets of it in the sense that the recommendation now is 150 minutes a week, which is hard. That's 30 minutes of keeping your heart rate elevated 5 times a week. It's hard to do. But if you are able to follow keeping your weight down, stretching your hamstrings, keep your core strength, which means abdominal strength and lumbar spine extensors, and cardio strength, or cardiovascular health, then you tend to be better overall. From a stretching standpoint, it's physical therapy. Patients do benefit from going to the physical therapist. It helps them to learn, but the caveat would be that they need to do it on a daily basis. So if we move around this circle of pictures here, hamstring stretching is maybe the single most effective thing. And there are a variety of ways to do it. This is a pretty simple one: pull your knees to your chest. You know, stretching the extensor muscles in this yoga type pose tends to really be quite helpful, and it can be a gentle hold to stretch both the hamstrings and the lumbar spine. Then we get on to strengthening. So that core strength would be things like bridges and crunches that are shown here. And then finally, we add extensor strengthening. And this tends to be the latter stages of physical therapy, because this tends to be harder, where the patient's prone and lifting one leg and one arm, and then ultimately being able to do a full extension of both legs and both arms. These things tend to, those methods tend to treat most of the lower back pain rather than surgical indication. But as things go on farther down that Kirkcaldy-Willis cycle, then you get other symptoms. Maybe it's harder to stand. Maybe it's harder to walk. It may not be entirely sciatica. It may be just this complaint, like, I can only walk a few minutes before I have some compulsion to sit down or lean forward. It may be not even leg pain. It may not be buttock pain. It may be just simply back pain. This is where we start to drift into spinal stenosis. So spinal stenosis is also pretty ubiquitous. All of us will have it to some degree. And if we take a look here at the top, this is a pretty normal looking spinal canal here. This is some moderate narrowing. You see this white starting to disappear, and then finally ending up here where you hardly see any space. And even in this one patient, normal here, moderate here, and pretty severe spinal stenosis here. So, you know, you have a look at it here. Here's a little closer view at it, that you can see the lumbar spine here with the spinal canal and the nerve rootlets, and plenty of CSF here. But in this particular picture, that white circle is down to a triangle, or, you know, as they describe, a trefoil shape, and it's driven by enlargement of this facet joint, thickening of this darker structure, the ligamentum flavum, and bulging of the discs. And those lead to kind of this overall shape of becoming narrowed. So the disc bulges seen in red, the flavum thickens, it enlarges, and then the facet joints enlarge, and then you end up down to a triangle here where the spinal canal is just narrowed. So the transmission lines become more attenuated, and the electrical current from a simplistic standpoint just cannot traverse that area as quickly as somebody would like it. So they are able to walk maybe 5 minutes, 10 minutes, maybe a block, a kilometer, that kind of thing. But then after that, they might feel some compulsion because they're not able to keep up. So if they stop, sit down, if they lean forward, they tend to have some relief, and then patients feel better. So if that is what is developed and it is not calming down, conservative care is largely the mainstay of treatment. It might be similar things, physical therapy, non-steroidal anti-inflammatories. If there is a great deal of radiculopathy or sciatica or claudication, sometimes we try gabapentin. It can be helpful. It's not universally effective, but is inexpensive and worth giving a go to. If these symptoms don't, say, resolve with that first tier, then going on to epidural steroid injections can be helpful. Physical therapy should be thrown on there. And then finally, if all else fails, surgery, quite effective, okay? So in the surgery realm, it would be something called a laminectomy, okay? Removing that back covering to the spine, and it makes the physical space and volume open. We would remove any offending structure, whether that be the lamina, the flavum, the medial aspect of the facet, disc, osteophytes. There's a limit to how much we can remove. If I remove too much, say I have to remove an entire facet joint, then we have to escalate surgery into a spinal fusion. So here is a pretty simple patient that had classical claudication, could only walk maybe not even 100 feet before having to stop. And the reality of this is that this physical volume is so dramatically narrowed that none of the conservative treatment ultimately works. We remove the material in the midline here, and you end up with this nice space where the dura is inflated. There's plenty of CSF flow, and now those electrical signals can get down into the legs, and the patient's able to walk better, and they feel dramatically better. If we keep going, though, and we find that it's not just spondylosis, it's not just spinal stenosis that is managed with some rest and epidural steroid injections and therapy, and the body goes farther down that Kirkcaldy-Willis cycle, then the instability can set in. And what that means is that the joints themselves maybe don't hold the lumbar spine in the correct orientation. So it allows for some translation of the vertebral body. And the key here is going to be this diagram, where if you imagine one vertebral body stacked one upon another, there is a nice cylinder. And if the cylinders align, the volume they share in here is nice and large. But when one translates forward, the volume that they share becomes quickly narrowed. Okay, so this is classical spinal stenosis from a spondylolisthesis. Now, this is one of my favorite pathologies to treat because it is highly reliably treated with surgery. And if you look here on this CAT scan, these vertebral bodies here in green and yellow, these line up nicely, but very clearly here, there is a translation of this L4 vertebral body forward on top of this fifth vertebral body. And if you see this 90-degree turn that has to be made by the nerve rootlets, this is where the pathology lies. So if this is the scenario, it's not responding to conservative care, then surgical treatment with a spinal fusion and a laminectomy will really dramatically make this better. It can be done even minimally invasive, like something like this through a couple of tubular windows. What we do here is we physically enlarge the space by removing a midline swath here to enlarge the physical volume, place vertebral screws into the bones, which confers some mechanical stability early, and then ultimately these two bones will grow into one bone, solidifying, hence a spinal fusion. If the spondylolisthesis progresses, then sometimes we get into really a more dramatic arena where the patient just has trouble standing up straight and they end up deformed. So this is pediatric scoliosis. This is classically known. We see this all the time where a child is crooked as they grow, and we're able to straighten this and improve this with surgery. But here's an adult, okay, has gone on, and this doesn't happen overnight. This happens over decades where there's a gradual drift. I just can't stand up straight. I really can't maintain my posture, or I can only maintain my posture just for a few moments. But if it really becomes overwhelming, it can be corrected. This becomes really a much higher complexity, but this is really what I love to do. So here's just a simple case example, 75-year-old. So, as we're getting older, we start to see this in all kinds of groups, whether it be males, females. Their scoliosis develops. There is the reality of having other medical comorbidities, hypertension, osteoporosis, chronically struggling with this pain. And on this one sagittal MRI, we can see that there is a spondylolisthesis both at L4-5 here and L5-S1, and it results in some compression upon the nerve. Failing conservative management, PT, anti-inflammatories, medications, pushes us into treating the global picture here. So we can see really a curve that is primarily in the lumbar spine as opposed to a pediatric curve, which tends to be higher and really is now as high as 70 degrees through this area. But there is also this fractional curve down here at the lumbar spine, leading to two curves and a loss of lumbar lordosis. And these numbers can get really large here. 70-degree curve is really quite debilitating for a lot of people. The main thing, though, might be even this dramatic shift of almost 6 centimeters off to one side. So they really can't maintain their overall posture. Their lordosis becomes, compromised. And in all of us, now this is more of the surgeon's world, where there's this fixed relationship between the sacrum and the hips that dictates kind of what we call the pelvic incidence. So we're born with this, we maintain this through our lives, and this patient has something around a 62-degree pelvic incidence. And that's about plus minus 10 degrees is where this patient wants to be, but she's almost 20 degrees off from that. So as we go through this, what do we do about this? There are a variety of ways to treat it, all through a posterior technique, through the abdomen, going front and back, minimally invasive robotics, navigation, releases. But this is ultimately what we're able to do here. We're able to correct this curve. It's a lot of hardware, but this patient can walk, this patient can stand, and this patient probably grew 3 inches at the end of this case here. So, beyond that, we look into the future. Where's the future going to take all of us? 3D printing from a tech standpoint is here. It's really quite useful. If I have a badly deformed patient, I can even get from a CT scan a physical 3D model to have in my hands, which helps me to understand what is happening in the apex of this curve, where sometimes the 2D picture on my screen doesn't give it. We can even have 3D printed material now. This is titanium 3D printed, and we can even go at the molecular level to treating the titanium with materials such that it gets bonded at the cellular or the molecular level, so that there are anions and cations like a nitrogen ammonia group here, which can help to fight infection. This kind of grainy appearance to it lets bone cells grow onto it. In the operating room, we can look at really, really dramatic advances in tech. Some of this is not fully to fruition, but there's navigation that is here. There's robotics that are being used. It hopefully probably won't replace me, but it really is coming. And I think of it when I'm teaching as the concept of maybe we can avoid an error before we even make it, whereas everything else we do is reactive. We've made the pass, we've made the surgical move, and now there's some consequence to it. With navigation and robotics, maybe we can see where we're going before we even get there real time while we're working, and that is maybe the gold standard behind what we're going for. And then if we look at like kind of more in vogue kinds of things, is there a concept of stem cell treatment? For spinal cord injury, this has been a hot topic for a long time. The data on this is not there, okay? The harvesting of stem cells seems to be, it should work, but it largely has not worked, particularly for catastrophic injuries like spinal cord injuries. But if we look at those same stem cells and we go a little farther down the differentiation line for osteoblasts, those stem cells can be de-differentiated into the osteoblast lineage, and we are actually using those stem cells to help the body build bone when we're treating it surgically. Maybe the future would be that will we get some kind of viral vector or something that can be injected into a disc which restores the extracellular matrix of the disc and really lets us auto-regenerate or turn back the clock on aging in that disc and unwind that Kirkcaldy-Willis cycle? Maybe that's the future. Not here yet, but that's hopefully where we're going. So we all evolve, okay? Our lumbar spine, we start out as four-legged crawlers, and then we work our way up to 2 legs, and then maybe we're with the cane and 3 legs. But we can alter that overall path, okay? The concept here is use it or lose it, okay? So exercise, be good, stretch, keep your weight down. This is really the main tenets behind lumbar spine maintenance. So thank you for your time. I know it's a lot of material to hear for some of you as early as 5 a.m., maybe 1 a.m. or late into the evening. I appreciate you listening to me and hopefully it was helpful to you.
Thank you very much. It was very, very good.
Thank you, Shavinda. Shavinda, that was wonderful.
Yeah, Karunian,
wonderful.
I have a question to you. Karunian,
yes.
During part of the lecture, someone was disturbing with a call. I don't know whether everyone else heard it or not. There was a lot of disturbance.
I heard it too.
Yeah,
you're right.
I think Karunian, you must tell people that they should mute their microphones, or they should move out of the room because it's a disturbance to everyone else.
Sure. No, I was muted. I think most of us were muted, but some of us maybe not. I will make it a point to make that announcement going forward. But any question for Shavinda?
Can I ask this is Shanti here. Firstly, Srivinta, it was a beautiful explanation of our lumbar spine. The more I looked at it, the more I became conscious of my lumbar spine because I had a birth defect, a slight scoliosis, which now I'm told now has become so bad. It has really gone in, like one of the x-rays that you showed is really the lumbar spine, the scoliosis, severe scoliosis, intervertebral disc, narrowed, osteophytes, and I have from time to time the sciatica. I'm going to see a spinal surgeon on the 30th of June. I know corrective surgery, we are all going to be 80 soon. Not yet, but there we are. It may not be a possibility. What are the options that I do have?
So it really pretty classical kind of symptoms, okay? And there is a dramatic spectrum, okay? So surgery is the last resort, okay? And it's not to say that just being, the number is not important. 80 is not really the important aspect of that. It's really the health, right? Because there are some terrible 50-year-olds and some really quite good 80-year-olds. But the mainstay, I would say, if you haven't done physical therapy, you should certainly start with physical therapy. Just the presence and magnitude of the curve itself doesn't necessarily mandate surgery. It's still the last aspect. So I would say therapy, maybe an anti-inflammatory, and if there is really a lot of sciatica, an epidural steroid injection can be quite effective. even if it's palliative, okay? If the injection gives you, say, 4 to 6 months of worth of relief, it is entirely conceivable that somebody would continue to maintain with episodic injections, and that would probably be the vast majority of patients treat with therapy, epidurals, non-steroidal anti-inflammatories. The key being you have to be diligent about doing the exercise and being active.
I'm doing the yoga and I had the physio and I'm having the chiropractor now looking at it and twice a week. But I just don't want to go down the route of surgery. But
Right.
I just want to, the pain is terrible. Is there anything that stops me from having an epidural, something steroid injections that I should be careful of?
You know, if maybe the main thing that limits some patients' ability to have an epidural steroid injection is the reality of needing anticoagulants, which are pretty common, okay? So if somebody has a history of AFib and they require some kind of anticoagulant for stroke prevention, it is a risk balancing ratio there. So, you know, pretty common to have AFib, and a great number of my patients are on some kind of anticoagulant. If they're able to temporarily stop it, then it's still an option. If somebody has, for example, a St. Jude's mechanical valve, then probably the risk-benefit ratio of stopping anticoagulation is not there. But for you, if you're not taking anything from an anticoagulant standpoint, you're not a brittle diabetic, then an epidural steroid injection.
As we all are, most of us are Asians are diabetics, but I'm not on insulin, but just went on oral.
Right.
But I just wanted to know, is there any particular question I should ask the spinal surgeon that I'll meet on the 30th?
I think you ought to ask, you know, whether the character of therapy that you've done has been adequate. If there is a role for, like, say you have a lot of sciatica, is there a role for trying a little bit of gabapentin? Because that is a pretty simple thing to try.
Yeah. Anyway, I may send you my X-ray for you to have a look at it and
Oh,
say
yes,
what
please,
you have.
please do. I'm more than happy to have a look.
Yeah.
Thank
you very much. So I was really glued to your presentation because it applied to me. So I'm sure there's a lot of other questions people will want to ask. And thank you very much indeed. Thank you. Enjoy.
Thank you, Shavinda. Shavinda. Yeah, Saro, you go ahead, Saro.
Yeah, Shavinda, could you let us know a little bit what you think about position and posture and positions like at sleep and so on, especially posture and so on, how that would affect subsequent development of back pain?
You know, I get asked it quite a bit, okay, particularly with relation to, should I buy a particular pillow? Should I use a particular mattress? There really is no dramatic answer to that. Some of it is in the sense that when you're sleeping, you have certain habits that develop over your life. It is really pretty difficult to alter those realities when you're sleeping. If somebody uses, and I think very few people these days would use something like a water bed or things like that, those are probably pretty poor. If somebody's mattress is in good condition, I'm reluctant to tell someone to change it, but if they are changing it, most patients benefit from a firmer mattress rather than a very soft one. It doesn't mean sleeping on a rock or on a board, but you know, a firmer mattress, most of them have kind of a foam topper on it, tends to help. From a posture standpoint, sitting is really a reality of life and sometimes really hard for some people to do. If you're seated in position, the ideal seating position, if you're working at a desk for some protracted time, is to try and keep your knees slightly below the level of your hips, okay? It tends to put a little bit of lordosis into your lower back while you're sitting and can improve your posture while you're sitting and tends to help. If the chair is quite low, that would maybe reverse that relationship, where if the chair is quite low, your knees will be higher than your hips and be harder on your lower back. So raise the seat a little bit higher, maybe sit towards the edge of the chair. It'll tend to force your knees below you. That is maybe the postural aspect. From a standing standpoint, I would say, it's common to have some fatigue develop, but exercise, whether it be, it doesn't have to be running, it doesn't have to be jogging or anything dramatic, just simply walking will really increase the strength of those lumbar spine extensors. The key being, it's not so much going for a walk with the dog where you're stopping every 2 minutes. You're looking for a 30-minute session where your heart rate is elevated. That's really where the work happens, and that tends to improve all of these postural aspects.
Thank you.
Thank you, Shavinda. Shavinda, yeah, Mohan, go ahead, Mohan.
Shavinda, thank you very much for a very interesting talk. Learned quite a lot, and it was nice to go through what we learned in our anatomy days. And also, it was very nice to know that you travel far and wide to help people, which I don't know whether something that is commonly done by American physicians and surgeons, but it was very nice. And yesterday was Posong as well. What I want to ask you is, on one of the scans that you showed, there was spondylolisthesis L4 on L5. Is that the commonest site for spondylolisthesis? And the other thing is, mostly it is L4 being anteriorly displaced on L5. Can it happen the other way as well, if not due to wear and tear by, say, trauma? Is that something that is known in spinal surgery, that the site is commonly the L4 on L5 and it is always L4 anteriorly on L5?
It's a great question. So L4-5 tends to be the most common level involved in lumbar spine pathology. Probably the root issue is driven by the anatomy, in that most of us with 5 lumbar vertebrae, the L5 segment sits just below the iliac crest and has some mechanical stability by being a little bit more deeply seated in the pelvis. So you look at the physics of that, the L5 segment is relatively fixed, and the L4 segment, as in comparison, has dramatically less restraint in comparison to 5. Whereas, like, say, if we look at 3 and 4, they largely are of similar physics in that they're both relatively more mobile. So L4-5 is in fact the highest incidence of pathology, whether it be a disc injury, spinal stenosis, spondylolisthesis, or even a scoliosis. Having said that, maybe if we expand our view, 90% of human pathology probably emanates from L3 to S1. So if somebody happens to have pathology that is primarily L3-4, it's not so unusual. If somebody has pathology that is L5-S1, it's not so unusual. But to your point, that the anatomy that drives L4-5 being the highest incidence is really that probably deeply seated L5 in most of us.
Thank you. Thank you.
Shavinda.
Yeah, Shrima has some questions, and then I have a couple of questions too for you.
Shavinda, thank you so much. That was a very good lecture.
Spinal
I appreciate that.
Hold it, one person at a time.
Neonatal spinal bifida, do you handle them?
I'm sorry, can you say it again, please?
Neonatal spina bifida, do you handle them?
I do. So spina bifida, as just a term, like, it is common to have a little bit of spina bifida as the L5 vertebral lamina doesn't close in a certain percentage of us. Now, if we go on to say myelomeningocele, that is a pathology where not only has the lumbar spine not closed, but maybe the neural structures have come through the skin. So it depends, some patients with that will have relatively mild to no findings and they're really functional. Other patients will be entirely paraplegic. So from the birth time, that would be the first things would be to close the spinal defect. Just get the dura closed so they don't develop meningitis, and then ultimately close the skin. A lot of those kids, once that's closed, then they go through childhood fine, and then as they hit adolescence and they start to pick up some body mass, now they've overcome the physical structure, and their functionality that they had when they were 3 and 4 and 5 starts to wane, and now they maybe need surgery, whether it be from a spinal deformity that is developed. A lot of the caveat behind treating myelomeningocele is that a lot of the children who have more pronounced disease that needs ultimately surgical treatment have been through so much medical treatment that they have relatively compromised immune system, and so they face a higher level of infection. So most of these are done in particular, tertiary care centers, that kind of thing. I'm fortunate I'm at Yale, so we see quite a bit of this, and so that kind of thing is done, as opposed to, say, general community treatment, probably not as much.
Shervinder, why I asked you that question is because now intrauterine stem cell is being introduced for most fetal abnormality, which are detected very early. Now the stem cell comes into this, they can, because you were talking about stem cell. Do you know any knowledge or any advancement in that? Because it's something to do with cell migration, you see.
True. Okay. So if we look at myelomeningocele, okay, probably even better than that would be preventative, and so a lot of it has to do with folic acid. So if we're able to keep folic acid high in females of childbearing age, then by the time that they conceive, the challenge would be that if they are not taking prenatal vitamins, if their folic acid levels are not high enough, by the time they are pregnant, they may be well into their first trimester and may miss the opportunity to really prevent it. So that's probably the most effective methodology, the most translatable to global health would be to have all women of childbearing age be with a multivitamin of some kind. That would probably curtail the amount of spina bifida that occurs globally by dramatic numbers. But if we look at those, say, the other subset of like intrauterine discovery of some of these pathology, there is even intrauterine surgery that can be done, less so for spinal pathology, but for cardiac abnormalities and things like that. Stem cell treatment for the specific aspect of myelomeningocele, I am not aware of any trials that are being done to that. And what I would say here is that while those things are somewhat new age and sexy and they sound really good, I would say a simple folic acid pill given to every woman between the ages of 18 and 40 would go so far in this world to halting or dramatically cutting the number.
Thank you. Shrima, go ahead.
Hello, Shervinder. Thank you so much for your lecture.
Sorry.
Every mother gets folic acid, FGF, the standard therapy.
Yeah.
Okay. Shrima has been putting the hands up. Go ahead.
I've got spondylolisthesis, and I find it very difficult my weight is very difficult to maintain. I'm just wondering, apart from surgery, is physical exercise, physiotherapy? I mean, I can't take anti-inflammatories because I had bad attack of hematopoiesis, so that's out. Apart from surgery, would any physical exercise be helpful?
Oh, definitely. So it may be, say if you have a spondylolisthesis, but you really are impacted or impaired in kind of some of your function, the thing would be to say, like, what activity are you able to do? So in plenty of my patients who have spondylolisthesis, they may find it, while I tell them to exercise, they may find it hard to exercise. They may find it difficult to actually go for a walk, much less run or something like that. This is where things like a stationary bicycle, and more specifically, maybe a recumbent bicycle where you're seated, is an excellent way to get exercise, strengthen the lumbar spine, and get that cardio exercise. And when you're in that seated position for cycling, oftentimes it is more favorable for the spondylolisthesis, that little bit of forward flexion tends to make the physical volume around the spinal nerves larger. Just think back to surgical days or a pregnancy epidural where someone is asked to lean forward so that a spinal tap can be done or a catheter can be placed. That little bit of lean associated with cycling can really help open up the volume for the nerve root and allow you to exercise. So maybe get a stationary bicycle that, you know, they're relatively widely available. You can even convert a standard bicycle into a stationary bicycle because they have these elevated clamps that are not too expensive and really can help quite a bit. Not having NSAIDs is not, it's not, you're not unique to that. That is pretty common, especially to patients who are either have a bleeding diathesis or have had some difficulty with NSAID tolerance. So I might say, why don't you ask about trying some gabapentin? It might really be helpful. A standard dose would be 3 times a day dosing, but you know, plenty of patients will get some relief with just a bedtime dose. It's a little bit of titrating, and there's such a wide range from 100 milligrams all the way to 900 3 times a day. It's worth trying if you haven't given it a try. There are some other analogs of gabapentin, which are some are more expensive, for example, Lyrica and things like that. But gabapentin, if you haven't tried it, you ought to give that a go.
Thank you very much. Thank you very much.
Thank you. Thank you. Shovinda, you know, first of all, thank you very, very much. That was a fantastic lecture and very, very proud of you and truly wonderful lesson for all of us and brought us to our old days, as Mohan said. I have 2 specific questions. Thank you. Thank you. And I have 2 specific questions. Number one, if you have L4, L5 spondylolisthesis, and I have it, and that's the reason I'm asking, you know, I do the flexion exercises, crunches and so on. Can you do the extension exercises? Because that team seems to impinge on the narrowing, it narrows the L4, L5 nerve root coming out. Can you also do extension exercises?
You can. I think the caveat would be that everybody has to know the nuances of their own body, right? So it may be true that you benefit most profoundly from flexion type exercises. And it may be the reality that extension exercises really provoke your particular scenario. If that's the case, you should probably avoid extension exercises, specifically like that Superman pose with where you're prone and trying to extend your hands. But you could probably get extension strengthening from cardio exercise because you will use your paraspinals in that regard.
Okay, and one other question. You know, the time I get my back pain, and perhaps the only time, is when I sit and concentrate and do computer work or sit in a place and concentrate. What is the relationship to concentrating and back pain? I mean, when I'm relaxed and laughing around, I don't get pain even when I sit down, but when I intensely work, I get pain. Is that common, or is that...
Yeah, probably common. In one hand, you know, maybe the busyness of your mind is on other things when you're having fun, right? So you're less attentive to your lower back pain, but it also could be the logistics of how you're doing your work, right? Is your workstation set up in an ergonomic way? Is there maybe some role to making some alteration to your chair? Should you get a chair that is a little taller or maybe has an adjustability component to it where you can raise the height of the seat and get your knees a little bit lower than your hips? You probably will find some improvement with that. If you put a little bit of just even a slight touch on your lower back with a little bit of lumbar support, right? As say, if we think of like sitting at a bar stool where there's no support behind you, that is definitely a harder chair to sit in than even something with a simple amount of lower back support on it could probably be helpful to you. So I would say for you, maybe swing by Costco and get a lumbar chair, one of these work chairs. It probably will make a big difference.
Lumbar chairs that's a category of chairs, are they? They are called.
No, I'm just using that term. Like if you think of these adjustable office type chairs, you can adjust the height. You can adjust the arm support height of it. That's the advantage. But you know, really a regular dining chair will work. You know, if you find yours is low, or you know, maybe you're sitting towards the front edge of the seat, okay, which will tend to drive your lumbar spine into a better position, and then keep your computer, you know, in front of you rather than say on the couch, you know, leaning over the coffee table, that kind of thing.
Okay, thank you. I'll try that and see and let you know.
Yeah, I have a question for you.
Thank you very much. Yeah. Any other question? Yeah, Milroy, go ahead.
Arul, I have a question.
Sure. Milroy and then Stanley. You have time to ask Stanley. You can ask after the.
Okay. I do that all the time.
Okay, Milroy put his hand off. Milroy, you want to ask?
Yes, surely I have spinal stenosis, and then great problem with it. Started end of last year. I could not walk. I got like an electrical shock behind both knees. I could not walk a few feet. And then I went for physical therapy. I took some, I think, more Advil, few. And then physical therapy did help me. Quite a long session. He strengthened my muscles, everything. But still, it was not going away. So I went for an epidural 2 or 3 months ago. It worked for 1 week. So the guy called me and I got the epidural yesterday. So I feel much better yesterday. So I want to know how often can I take this cortisone and then for how long? Because I'm on Plavix, so I have to stop the Plavix for 6 days.
Right. So it is a pretty common scenario that you're describing, okay? And I break it down into maybe 2 groups, okay? One is the acute phase, and maybe one is the more chronic management phase. So if in the acute phase where you're well and you have relatively sudden onset of this more recent experience of having trouble walking, doing multiple injections in relatively close proximity to one another is reasonable. I will usually tell patients, give it a go to judge the outcome of an injection at about 3 weeks after the first injection to know, 1, you know, did it work? And 2, did it last? The concept being most of the steroid formulations will linger in a crystal structure for about 3 weeks' time, okay? And so after that point, at the 3-week mark, most of the medication is largely gone. And so then at that 3 to 4 week mark, it is a good point to judge, okay, are my symptoms under very good control, or are they, the scenarios might be that they are 100% better, which is of course the goal and no further injections are needed. Are they partially better, meaning they're better, but it's not good enough? Then repeating a second or a third injection in relatively close proximity is quite useful and should be done. So in your case where you got relief, but it only lasted a week's time, repeating it again is entirely reasonable. Let's say if it keeps happening in that regard, to say that you have an injection and you do respond, but it is less than the ideal time, like you're only getting a week, 2 weeks, a month of relief after, say, 3 attempts at it, then it's probably less practical for you to maintain your spine with injections. But you could have, I usually use the number of 3 to 4 times during the course of a year. So those patients who are out of the acute phase, but are in the more chronic category where they have recurrent symptoms, but they're largely able to manage, having an injection every 3 to 4 months' time is entirely reasonable.
Yeah, so I feel much better today after yesterday. So I hope it will last. What is the risk of osteoporosis? Is that true that you can get osteoporosis?
True. I mean, it is a steroid, right? So from at the biologic pharmaceutical level, steroids will, as a steroid, reduce the overall density of bone. However, the difference being local injection and systemic steroids is dramatically different, okay? There is some literature that talks about the development of osteoporosis or epidural lipomatosis from chronic repeated injections, but we are talking about patients who are having it done for decades and probably have an underlying degree of osteoporosis driven more by natural history rather than just the medication.
I got a bone density scan, whatever it was normal.
Yeah.
So, thank you very much. If you don't mind, can I send my CD or X-rays to you so you can have a look at it?
Absolutely. No problem. Send it.
Thank you very much for your lecture. It was very interesting and very advanced than I heard long time ago at the Sri Lanka Medical Association when you had just passed out in that time. You had just qualified. This was very education, and because these are the problems we have. So thank you very much. And
You're welcome.
All the best. Take care.
Thanks, Milroy. Thank you. Thank you. Stanley, you have a chance to talk to your son.
Yeah, okay, thank you. You know,
he won't charge you.
You guys might be very jealous of me because in the midst of patients, suddenly I call a consultation. You know how did not get orthopedic consultation? I get an instant consultation. Okay. All these questions have been asked on the lower spine. Now I'm going to go up on the cervical spine. Now I still drive, so sometimes a limitation of movement, I just want to turn right. I can't. It's so difficult. What can I do to improve my movements of my neck, especially while driving?
You know, it's a pretty common complaint that most of us will have an asymmetric loss of range of motion. It may be that turning to the left is more difficult and turning to the right is less difficult, but that's true for almost everybody. You know, even myself, I can't turn my head to the left as well as my right anymore. So it is a pretty normal kind of a thing. What I would say is, from a maintenance standpoint, there probably is not that much to do. If somebody has dramatic amount of neck pain, then exercise again is the main things. Push-ups tend to help. Latissimus strengthening exercises tend to help. Those are probably the mainstays of doing it. If somebody has a tremendous loss of range of motion acutely, it can be maybe driven largely by inflammation and paraspinal spasm, and those largely tend to resolve themselves from the acute episodes or over the course of a few weeks. For you, I would say don't do anything specifically, just leave it and drive more carefully.
Shavinda,
thank you very much.
You're asking your dad to drive more carefully. I don't think he can do that.
Yeah.
I don't think you can do that. But anyway, Shavinda, there's a question on the chat group. Number one is, what about chiropractors? What do you think is one question. And so I don't know who's asking the question. Maybe they can, the chat person, whoever it is,
Hello.
can...
I think it's Siana.
Yeah, it's Siana Maruf.
Yeah, oh, Siana. Yeah, okay. Yeah, Siana. Yeah, sorry.
Sorry, I was just co-hosting here, but it was a very interesting lecture, and I'm talking to you from London, Shavinda. It's I'm a GP myself in the UK, and back pain is bread and butter for us, as you might imagine. So my three-part question was actually, I get so annoyed when I watch the Voltarol adverts on television, how they market it and, you know, how they make people buy for back pain. I'd be really interested to know what you think, whether there's any efficacy there. I can ask these in parts so you don't get lost, or I can just tell you the whole lot and then you can answer them. What do you prefer?
You know, go with all of them. I'll go through it.
Okay. And then, so the reason for asking about topical therapy, and some of the others might be interested, is I have very good results with lidocaine patches for some of my patients with probably more nerve root impingement pain, so sciatica, etc. And they can't have non-steroidals, or they can't have morphine patches, opiate patches. So I'd be interested in that topic, concept of topical pain relief for back pain. Microdiscectomy, I think, has been revolutionary in general practice for my patients. You know, to go in and have keyhole surgery and come out walking and carry on with life so quickly. I've listened to a lecture this morning about gynecology and the pitfalls of mesh when they do, you know, perineal repairs. So I just wanted to check with you that there was no pitfalls over the years with microdiscectomy, and, you know, have there been any nasties that have come out of that? And the final thing, what did I say? Oh, this was just coming back to your father's question there. I also want to ask about the neck, because I found myself advising patients sometimes to sleep with a travel cushion, just because, you know, they are getting quite severe spasm in their necks. And could this ever be harmful?
Okay, so you know, all three great questions that come up every single day in my practice as well. So I would agree with your general annoyance about the use of Voltaren gel for the lumbar spine. I think it is a very useful drug and medication for hands, okay, because it's really skin and bones, and I think you can get meaningful penetration of the medication down into osteoarthritic hands, and I think that's probably the index indication by which the medication was created. It's used in the lumbar spine, but I would agree with you. I think it is difficult to see it penetrating, because even in a thin patient, the distance from the skin to the surgical pathology, if we were operating, even in a thin patient, it might be 3 to 4 inches deep. So it is really unlikely for Voltaren gel to penetrate that far. Now, I don't think there's any harm in doing it except to the patient's wallet, because here in the States, Voltaren gel is very expensive. So I generally steer patients away from it. Topicals like a lidocaine patch, you know, again, I would say no harm except to the patient's wallet. Here in the States, Lidoderm patches, the brand patches, 5% lidocaine, is so dramatically expensive. But there is, here there's a brand called Salonpas that is, I think it's just 4% lidocaine instead of 5%. It's, you know, fine, and those are inexpensive and fine, you know, fine to try, and I think little harm in it. It gets commonly asked, so I usually tell patients, give it a go. If it works fine, continue to use it. Going to the microdiscectomy question, microdiscectomy can really be like a lifesaver, and it is a small surgery. It takes about 30 minutes to do, can be done as an outpatient for the most part, and can make particularly lumbar radiculopathy, sciatica better. It doesn't have to be only discectomy. It could be if somebody has, say, a sciatica, it is driven by spinal stenosis. While they have bilateral findings, they may have unilateral symptoms. Really fine to proceed with surgery for that if they fail other conservative, and really expect to have very good results. From a pitfall standpoint, there are always complications, right? Those surgeons who don't have any complications either don't operate or they're lying. So, you know, always things can go wrong. And so hence this would be the concept of trying our best to make surgery the last result. The cushion question, you know, again, you know, fine to sleep with the cushion. There's no long-term detriment to it. I get asked on a relatively regular basis, you know, is there a better pillow? Is there a better brand of pillow that I ought to try? Because there are so many, and some are very expensive, gel, foam, buckwheat, you know, all kinds of, and there's not a particular answer. As a general concept, I tell patients if they are back sleepers that they ought to use a thinner pillow. And if they are side sleepers, trying to bridge the distance between the side of the head and the shoulder, maybe they would use a little bit thicker pillow. I think, you know, a travel cushion is an entirely reasonable thing to suggest. And if it's effective, really no harm.
Thank you, Shavinda. You're very, very popular. More questions coming your way. I hope you'll be patient with us.
No
Otherwise,
problem.
I'll tell your father to talk to you. So, so you got to go on. Yeah, but I think someone asked a question about L5 arthropathy, and they got pain when they wake up. And I'll tell you, I have right unilateral facet arthritis at L5. The pain is severe in the morning when I wake up from sleep, but on walking for 5 minutes, the pain virtually disappears. Any suggestions?
Yeah,
Don't
so
sleep
that
is one suggestion.
yeah, that is a very common scenario, right? And so I think that while that, when you rise from bed and you have really an incapacitating amount of pain, and it is such a disturbing way to begin your morning, maybe the real highlighted portion would be that it lasts 5 minutes and then it disappears. And there is a little bit of, leave it alone, because I kind of joke to some degree to my patients. I'm like, the best thing you can do is stay away from the doctor, right? So if it really is about 5 minutes of pain and then the symptoms go away, it's well explained. The root issue is probably osteoarthritis. There may be some component of nerve root irritation or even compression from spinal stenosis. But if the symptoms abate, then you shouldn't do anything. Osteoarthritis is classically worse first thing in the morning, after sleep or after a period of inactivity, and then movement, heat, and a little bit of time tends to make most osteoarthritis better. But it is classically to be there every single time afterwards. So I think for this particular person, I would say, 5 minutes, leave it alone. You may find that you have to get up a little bit earlier. You may find that doing a little bit of stretching in bed might be helpful, like a simple knee to the chest kind of stretch before you get up. But if it doesn't give dramatic relief and it really only lasts 5 minutes, I probably wouldn't go through too much effort to chase it into surgery or anything like that.
Okay, very good. Thank you. Any more questions?
Yeah, I have a comment, Arul, not a question. Is that okay?
Sure, go ahead. Please do.
Now, I remember coming to America over 20 years ago, and Shivanda's dad and mom took me in the car, long distances, and I don't remember any restriction of his neck mobility or
oh, that's long time back.
ability. So
that's quite a long time back.
Yeah, this must be wear and tear and that sort of. so just to say that his driving was fine, absolutely fine.
Okay. All right.
I also have a comment.
Sure, go ahead, Narada.
It's a part of a question anyway. I just want to know, why did you do things differently from your dad and have the 3 beautiful girls first before having the boy?
There's no answer to this. There was a point where I would joke with my wife before my son was born. I would say, even the fish in this house are female.
Yeah.
To add to that, when our last pregnancy, or my wife's last pregnancy, I was thinking maybe I'm going to have a football team or a soccer team. I just really what a relief at the 4th attempt.
Arnian,
You guys have done very well. Yeah, someone, who's that?
I want to make a comment.
Yeah, go ahead.
I'm very impressed with you. You are such a polite and kind man for an orthopedic surgeon. The personality is different. And you seem to respect and pay a lot of compliment to your father and your family, you see.
Mother too.
Yeah, family,
Yeah.
That includes a mother. Why are you excluding her?
Yeah, I know. Because she's a wonderful lady. Yeah.
Now, this litigation is very high in the United States or anywhere. Orthopedic surgery has high litigation rate. Now, do you get involved in that? Also the insurance must be high as well.
Yeah, I mean, litigation, lawyers, are the root of so many problems in life, right? So, you know, there is a reality that all of us, but, you know, orthopedic surgeons are walking around with a bit of a target on our back at all times. So it's interesting. My residents ask about this, and it is a bit of risk tolerance kind of thing. It doesn't suit everybody, but there is a reality that you also, I'm of the mind that you shouldn't be paralyzed by this reality. It is something that we have to deal with, and that if we try to stay in the middle, whether that be avoiding lunatic patients, because let's be honest, there are plenty of lunatics out there that cannot be helped, trying to stay clear of those kinds of things, and trying to stay with good indications, that helps to avoid dances with the attorneys. When it does happen, you know, that's what insurance is for. So yes, premiums are high, and you know, someday I think it would be a wonderful, that's a whole different talk to get into, trying to take the litigiousness out of medical care by, you know, creating a system similar to airline pilots, where we have the ability to report and learn from others' mistakes while removing the individual penalties as such would be there. And, you know, but I suspect here in this country, it is an uphill battle to fight the attorneys who are deeply entrenched. Some places, interestingly, the attorneys are on their back heels, but you know, Connecticut is not one of those places, so you have to be mindful and try to stay clear of trouble. But it's probably what gives me plenty of these gray hairs also.
Unlike in other fields, surgeons have to be innovative. You know, it's not like other fields of medicine. You can look at a book like reciting a poem. The other aspect of medicine, which is said in the book, and you repeat it. But when you open, you must be able to proceed. You know, you must be innovative and able to think on the feet. That was the surgeon. You find a lot of our people from our country, they don't do surgery when they go abroad. They stick to medicine and other aspect of things rather than surgery. And I'm so delighted to see you. You're so confident in your surgery, the way you speak, but it's a difficult aspect, spinal surgery. Well done, ma'am, and very, very grateful that you were able to speak to us.
Thank you, thank you. Yes, Saro, you had a question.
Yeah, is there like a cap or a ceiling on the amount of litigation stuff in Connecticut? Like some states have, yeah, others can come.
You know, yeah, some states do have caps, right? California has caps.
Caps on pain and suffering, not on surgery, pain and suffering.
Yeah. So yeah, I mean, I would say the state of American malpractice, you know, coverage and care as a concept is poor. Okay. And that, you know, hopefully someday there will be some different take on it. The cynical part of me thinks that the attorneys really have too much money in their pocket, and that we as surgeons and doctors don't pool together the way they do. But that's also part of our reality, and that we are approaching things in it. We're trying to help patients, right? Whereas, you know, maybe they're particularly the people that we're fighting against here in these scenarios are really blackmail artists. So,
you know, I have a suggestion: send more doctors to the legislature.
Yeah,
there are too many lawyers in the legislature.
True.
True. They make the laws. Yeah.
Then Nilani is here.
Nilani, go ahead, Nilani.
Hi, Shavinda. I'm Nilani Gajavir. I was a Sugatapal. So your father can't forget me in a hurry. We were in the same signature group, sharing many anecdotes in life. Anyway, I have a very simple question. When we were young, hot fermentation for any ache was the home remedy. Nowadays, I know people with severe backache, the British doctors recommend a cold pack. Can you enlighten me about the cold pack? Good old days, we will think that the muscles will freeze. So that's the thing in UK at the moment. I mean, I'm sure elsewhere as well.
You know, there is no particular correct answer to say heat or ice as a concept. And in the classical acute injury, say a sprained ankle or a sprained knee, rest, ice, elevation, and compression would apply. So maybe if there is a dramatically acute injury, then ice might have some role, okay? But as a general, the patients who have more symptoms that are kind of slow in development and chronic, they tend as a generality to respond better to heat than to ice. Now I have some patients who will say, I feel better with using ice. Fine. Maybe the bigger thing there would be to be mindful of people's skin, because I have oftentimes seen patients come in with, whether they are thermal burns from heat or even ice burns where the skin structure is altered. The key would be not to place the heat directly on the skin or the ice directly on the skin, to have some fabric between the skin and the actual compress, and then to limit the time in which it's used. Similar in that concept are the sports rubs, Bengay, Icy Hot, that kind of thing. All fine to use. There's no particular answer. If they help, use it.
Thank you. Thank you.
Karunyan,
Yes.
Can I have a quick comment, please?
Sure. Please do, Banda. Banda is from New Zealand, Shavinda, and he's talking to you at 2 a.m. in the morning.
Oh my goodness.
Yes. And I
so you must have been very, very impressive for him to stay up and listen to you and ask questions. Go ahead, Banda.
I haven't felt sleepy even for 1 minute. One of the best lectures I have heard, particularly because I've got a lot of spinal problems following an accident about 8 years ago. I've got a L1, L2 fracture, but that's beside the point. What I want to know is, my surgeon said that he can do an operation, but he has to go anterior and he has to get another surgeon to mobilize my kidneys. That put me completely off. So I decided not to go ahead with the surgery. And I'm managing conservatively. And one of the best things I've done is to go regularly for hydrotherapy. It's 8 years and I have avoided sciatica so far. I don't take any painkillers. And I'm managing. Only problem is I can only walk or stand up for about a minute or two, and then I got to sit down, and then the pain goes, and I can then start walking again for a couple of minutes. So what do you think? Do you do most of your surgery with the anterior approach?
What I would say to that is, if you can manage the way you are, then really it is perfectly acceptable. And hydrotherapy, whether that be a hot tub or whatever it might be, if it is effective and leaves you with a good quality of life, that's really the main goal there. On the other hand, it sounds like standing or walking only for 1 minute is relatively limiting. Okay. So if that is in fact with a less than desirable, quality of life, a minute is not very long to do the things that you need to do. And say other things like an epidural steroid injection are not particularly effective. I would say as a concept, surgery can be done. Whether it's done anteriorly or posteriorly or some combination thereof, it kind of depends on the individual appearance of that thing. So as a concept, I do quite a bit of anterior surgery. It's not the only trick in the bag. Sometimes it's done through a lateral approach, and there are some new elegant techniques where you can approach the anterior spine through a 1 centimeter, 2 centimeter incision. And yes, you have to work around the kidney and the ureter, but it can be done without dramatic intervention. If it needs something like a more classical midline retroperineal exposure, it is common even here to have a vascular surgeon with you, particularly in the, like say, L3, L4 region where the iliolumbar vein needs to be mobilized. That can be very effective. And it depends, I have some patients who that will really terrify them. I have other patients who really are not fazed by it. So, I would say it needs a more nuanced answer that depends on the individual aspect of your particular imaging.
Thank you, Shavinda. That I really enjoyed your session. Thank you very much for that.
Oh, my pleasure.
Yeah. Shavinda, I don't know if you heard of Steve Kerr.
Yes.
Yeah, Steve Kerr is the coach of Golden State Warriors, a very favorite basketball team in California. And Steve Kerr had back surgery and went on a campaign against back surgery in a very generalized fashion. What is your comment to that? I mean, do back surgeries always have bad results as he had, or?
No, I mean, Steve Kerr's individual aspect of it would be that I believe the story is that he had supposed to be a minimally invasive surgery, suffered a dural tear during the course of it. I'm not sure as to whether it was unrecognized or recognized, and then had to have subsequent surgery as a result to repair the dura. What I would say is Steve Kerr, unfortunately the poor guy suffered, but as a generality, the concept of, extremes is in play here. He has a large soapbox, and, people look to him as a prior player and leader and a popular figure. And it's easy to believe all the things he says. It's not that he's lying, but his individual experience was poor. But I would say the vast majority of people who do well don't spend their time on the internet, don't spend their time on soapboxes. They have life to live. Sure. They have things to do.
Okay. Now, being Lakers supporters, we were not too unhappy about it, but
no, I mean, those are the. I use it. It's interesting. I like patients to voice their fears and concerns. And even things like the Steve Kerr material that is out there is useful because it lets you get your patient to a more informed standpoint. So we talk about dural tears. Dural tears are a reality of this. The dura is like wet tissue paper. It's not even a 1/4 of a millimeter thick. And so sometimes, particularly in revision surgery, a tear in the dura is commonplace. And, for the vast majority of it, probably 99% of it, you throw some stitches in it, you go on with your day, and the patient does fine. Sometimes it leaks, and it is a persistent problem. And it sounds like he had one of those more recalcitrant episodes. Maybe he had some, I don't know all of the details, but, from his own standpoint, what he was signing up for was very different than what he got delivered. And that goes to the reality that if you are a patient who suffers a complication, even if that complication is 1 in a million, if you are that 1 in a million, it is 100%. Whereas the other people, it's a fractional thing. So,
thank you for that. Any other question, comments?
Yeah, surely. I want to add, I was not clear. If you have osteoarthritis of the knee, which is better to start out, ice therapy or heat therapy?
For the knee, it probably is a little bit different answer than the lumbar spine, okay? Because the lumbar spine, probably a lot of that symptomatology is from muscles, and that probably tends to respond to heat a little bit better. For the osteoarthritis of the knee, it probably would be, ice would be more helpful because it may be driven by inflammation in the actual joint line.
Okay, thank you so much. Yeah. It's a simple question, but I'm not sure.
I have an answer for that. Long time back, I was in Sri Lanka and MOOPD, and on Wednesdays at Ragman, there's a fair and a lot of people coming. So Wednesdays are always busy. So Lucky Veerasena, if you can remember, is the chubby guy. He was the other MOPD. So this old man came and said he came for a cough and cold or something. And then he said, Dr. Matya, I have this pain in my knee. What can I do? Listen, Loka, I gave you sodicel mixture. Just drink it and take a little bit and rub on your knee. And that will take care of your pain. Little bit of psychotherapy.
Yeah, I know. Yeah. Okay. Any other questions? Shavinda, I told you it's about 45 minutes to an hour and a half, but you did too good a job, and so you got too popular, and all the questions came coming. Okay, just it's also wonderful to hear you. I spent a couple of years at Yale myself. I lived in Hamden. I think that's where you live, right?
I live in Bethany.
Bethany, yeah, okay, yeah. So it's wonderful to have you also, come from the same area. During my time, they started a program of preventing scoliosis in children by doing routine school examination, and then putting them and detecting them early. I don't know whether that still goes on. I presume it does. On the spine for scoliosis in children.
It is a project that continues, right? And it faces one of these public health funding issues. From my standpoint, I think screening all the children in 6th grade is an excellent way to have it done. You can get every kid, and it is one of the reasons why in the States we maybe do a better job at finding these pathologies earlier. Whereas, like, say, when I'm overseas, a lot of these kids get neglected, and a curve that would be caught and treated really goes untreated and gets into a much larger scenario and a more problematic thing. So I would say 6th grade screening is a good and routine part. It is varying between, some schools are not doing it, so it'll be more the purview of the primary care doctor, like so many things.
Yeah, it was started around the time, I think in the mid to late 70s. And I was at a place called Newington Children's Hospital. That's now part of Connecticut Children's Hospital.
Right.
And they had a very robust spina bifida program. And that's where they started the screening, and it spread to all over the country, I think, around that time. So it's wonderful to see you in that area. And more importantly, it just was a fantastic lecture. And you had too many more questions than I anticipated, but thank you very, very much, and thank you, Vijay, and to Kumi too, bringing up such a wonderful boy, and we're very proud of you, Shavinda.
I can just Shavinda, I want to get your comment. I was just looking up. Yale is supposed to be one of the best universities in the world, number 1 or 2 compared to Harvard. But I was surprised to find that the population of the Yale University is 70.1% blacks, 16%, 14% Chinese, 2.3% Asian. Is that right?
No, that's a New Haven. That's New Haven, I think, huh?
Yeah, it could be. It could be. I think that probably is not entirely. I don't think that's a correct number. But university admissions and affirmative action and race kind of things is a hot topic around the country, and even at the Supreme Court level these days, right? That Harvard has been sued by Asian students for being reverse discriminated against. So it is a changing world.
No, but I don't think it's 70% black.
Universities in the world. It's a great compliment to us as well.
But Yale is not 70% black.
Like
Right?
has a question.
No, it is not. It is not. But there is a very, sorry.
I referred it this morning.
But he's muted.
Sorry, what's that?
I see Pial raising his hand, but he's muted.
Oh, sorry. Lianage, you are muted. Lianage, you are muted, man. You got to unmute yourself.
You have to tell it.
You are still muted.
It's gone. He's gone off.
Gentlemen, if I missed anyone, I do apologize. Lianage.
He's gone.
He must have gone first. Sorry about that. Well, Vijay, Stanley, you can ask him and ask the questions of your son later on. He's in California, so.
No, I don't know for the question, but I can only have access to him.
Okay, no. For PRs, yeah. Any other questions? Can we let Shavinda go and take care of his 4 children and take them for tennis or whatever it is?
Stanley, how often do you all go kayaking? I saw you and your son taking the kayak out.
Nowadays, if I go there, I will go there because he has a house right in front of that area. And
You have
I
to wear
go
a
there, but
wetsuit.
whenever I go. So nowadays, not much. I haven't gone there for about more than 1.5 years, but at least once a year I go there.
So,
hello.
So
Hello.
let's close. Sorry, can we close
Pia came in the phone.
Yeah. Hello. Hello, Stanley.
Pia, yeah, go ahead. Go again.
Hello. Can you hear me?
Yes, please. Yes, go ahead.
Can you hear me now?
Yes, we can
hear you.
Yes. I got up at 4 o'clock in the morning, especially to listen to Shavi's lecture. And I postponed my trip to Sri Lanka also because of that. And I'm so thrilled actually to listen to one of my sons, within inverted commas. He's like a son to me. And it was such a useful lecture. And I also got the answers to most of my orthopedic problems. And some of these symptoms I shared with Vijay most of the time. And I am okay now, actually, and we are planning to go back to Sri Lanka next week or so. And one word is enough, I think, to say that this is a wonderful person, and I'm so thrilled to see that you speak with confidence and give all the answers the very best that you could do. And to make it short, I wish you all the best in the future, and hope to see you in Sri Lanka and enjoy the life as usual. And so thank you so much. And I got your entire lecture also, I think, on my phone, and I can follow it. So all the best to your family and to yourself, and I'll have a chat with Stanley later. Thank you. Guru Sarnai, bless you.
Thank you.
Thank you. Okay, thank you.
Thank you. Wonderful. Okay, ladies and gentlemen, I think that's for today. We have a little bit of housekeeping thing. Maruf is trying to organize get-together, gathering of the whole batch in August. So we need some volunteers to help in that. I think Maruf is here or Maruf is gone.
Where are you going to meet?
No, virtual. We'll have to have a virtual thing.
That's a good idea.
Yeah.
I'm here. Don't worry.
He was driving.
We will contact you all, and we will try and organize that. There are one or two other.
I think get the names. Yeah.
Yeah. No, Maruf, please respond to your emails and your WhatsApp messages. Yeah. We can organize something which is exciting for us. It's
okay,
really
sure.
Wonderful having children of our batchmates make presentations. Saro's son and Bobby's son, and now Stanley's son. It is really nice.
I don't know how to talk.
Beyond that time. Is there anything else?
Oh my God, you're on camera. Why don't you? I'm on camera. I'm on camera. I was on camera.
Hi, Betty.
Hello.
Hello.
Betty, you have any questions?
Hi, Milroy.
Hi, man. Good.
You're driving.
Yeah, I'm driving. I'm not driving. I'm being driven.
Okay.
It was nice.
All right.
Excellent.
Well, thank you everybody for having me. That was I do appreciate.
I'll keep in touch.
I appreciate the time and the attention. That's all. Some of you made a long effort and an early day for that, and even traveling in the car. So thanks very much. It was my pleasure.
Thank you. Thank you.
Thank you very much.
Thank you very much.
Thank you.
Thank you.
All right. Take care.
Okay. Bye-bye.
Bye-bye.
Bye.
Bye, Satrugnan.
I'm Arun. Bye.
Bye.
I think we have to thank Maruf and Karunian for arranging these things for us. It's very interesting, really, just to see our children all done so well and able to do all. It's very nice. I think it gives a very nice feeling to see. Karunian, you are muted. Karunian is muted.
Yeah, sorry. Yes, it does. It does give a very nice feeling, and it's good to see all these young people, in different fields and doing so well.
I need a plier.
Maru.
Okay, Milroy.
One question. One of our batchmates, he's not doing well at all. When I had in touch with him, when I talked to him, he said he feels even tired. He's having some terminal disease. So please try and send the email from us, giving all the encouragement. And those who know Abesari Gunawala, please speak to him. His wife is also,
what's wrong with Abesari?
I don't know. He got some terminal thing in the bone marrow.
Oh.
Yeah.
Milroy, does he answer phones? I'd love to talk to him.
Sad to see that. So
Milroy,
yeah.
Does he answer phones? Does he?
Yeah,
Does he? Can he does?
Yeah, I have been talking to him every week, give him encouragement. So please,
Sure, I'd love to talk to him.
Please talk to
Sorry,
him.
Saru, you had something to say, Saru?
Yeah, I was going to say what he has is like a hematological myelodysplasia type thing. He had multiple other things as well. We are in sort of touch with him as well.
Yeah.
He and Keith, are both not well, actually.
He's also not doing it, unfortunately.
No. Yeah. I don't know whether lots of phone calls are going to help too much, but probably any other messaging systems, whatever, would be good.
Yeah. Saru, could I have his phone number at all? Because I once talked to him a couple of years ago for a reunion, but we were close. We were all in the same age. You, me, and Abhay Singh, Abhay Sirigro, and Arlanand. Yeah. So I'd love to see.
I can send his contact information to you, Aru.
Yeah.
But
I didn't know.
treatment, I think
I didn't know you.
blood transfusions, frequently now. And so it's that kind of a situation.
Oh boy, sorry to hear that. He was such a happy person.
Yes,
and, we should try and get some. Is anyone in touch with L.U. Abesari?
I do.
Sri Lanka.
L.U. Abesari, he was in New Zealand.
He's in UK. He was in London.
He's in UK.
Can't we get him to come for these things?
In UK,
I wish we can get all these guys, in United States, there's Ravi Fry.
Reconstructive surgery he does.
Okay, I tried to help you.
I'd love to talk to these guys.
Abesari is in UK.
You have his contact information?
You want to plug it in? Okay. Okay, sorry.
Anyway, we should try and get to.
You have to get Nicetas. He doesn't want to come.
I know. Nicetas is in California.
Yeah, Sacramento. He doesn't want to come.
This is why my suggestion is let's have a plan for a reunion and tell everyone at least come once. So many guys, Koneswaran, Ravi Fry, Nicetas, so many guys around. Anyway, okay. Good to see you, Betimoni.
Hi.
Darling, good to see you, Vajan.
How are you?
You are in LA, we don't see each other. Good to see you again. Okay. Thank you, folks.
Thank you.
Thank you.
For putting this together.
Again, thank you, Vijay, for your wonderful son. He truly is a nice guy. He's a very, very nice guy. One of the few guys who sends me Christmas cards. Yeah. Thank you.
Okay, thanks.
Okay,
Bye.
Thank you.
Bye.
Bye, Narendra.
Bye.
Bye, everyone.
Bye, everyone.
Bye.
Bye.
Bye, Kodam.
Bye.
Bye.
Kodikar,
Bye.
Okay. Thanks a lot, Stanley.
Kodikar, do you hear me?
Yes, Stanley.
How are you?
I'm all right. There's a Vetti, no?
Pardon me?
That is Vetti, no?
Yeah, Vetti Muni.
Yeah.
Salim Vettimuni.
Bye.
And all Anandian.
Yeah.
Kodikar, you can't remember me.
No, I can remember you very well.
We were together for a long time.
Yes.
At Anand.
Yeah, and even Stanley is from Stanley
I'm
basically is
only
from
about
Anand.
3 miles away from him.
Pardon?
I'm 3 miles away from him.
Yeah.
Close by.
Very close by. And he's a good friend of mine.
Yeah. Stanley, what level did you join Anand?
Anand, I was in 1949.
Yeah.
I'm too old.
Yes, I think we were together in Kahawata's class.
Yes, that's grade 8.
Yes.
8th grade.
Yeah.
I
mean, we have been together from Velikili.
Yeah.
Not only Kahawat, what about Rajapaksa, the principal who became the principal later after he was the warden of the hostel?
Rajapaksa.
He was the warden of the hostel. Then he became.
No, all of us were together from.
Yeah. We were together in that classroom near the Saltry.
Yes.
That's right.
Can you remember the Saltry?
Yeah. Can you remember the Pirita? Baba known as Pirita?
I can't recollect, but
Baba no Baba no Lamba Usanai. Stanley, you can be remembered. Stanley,
Good old days. We are going to 1956.
Yeah. Do Baba no Lamba Usanai. Beri Sanyang Dele Malang. You remember that?
Of course, yes.
Yeah.
Varusa Vitarna, I forget their names now. D.A.D. Jayasuriya.
Yeah.
Can you remember? Why? Boris Marx and them were
Yeah, Boris Marx, Bijo, BJ Marx, Bijo.
See you next month, everyone. I think we are going to close at the moment.
Okay.
Thank you. I'm reaching
Thank you very much. Vettimuni,
Okay.
nice seeing you again. Bye.
Okay, bye.
Bye.
Really nice seeing you. All the best.
All the best.
All the best.
Thank you, Maru.
Bye.
Okay, take care.
Take care of yourself. Right.
YouTube එක තියෙනවා
record කරලා තියෙනවා.
ඉතින් YouTube කියලා කිව්වේ?
Yeah, YouTube එකේ record කරන්න බෑ. කවුරුත් record කරන්න තියෙනවා.
නෑ, you can check the YouTube and do it.
Yeah.